Hello, my name is Deborah Dooley. I'm a family nurse practitioner attending the University of Texas Rio Grande Valley, and I'll be discussing today transcranial magnetic stimulation and my proposal for its use as a primary treatment for major depressive disorder. The current first-line treatments that are utilized as set forth by the American Psychiatric Association include pharmacotherapy. Most practitioners will start out using one of our SSRI treatments. The second would be depression-focused psychotherapy, or a combination of both, the pharmacotherapy with depression-focused psychotherapy. And finally, electroconvulsive therapy, or ECT. Currently, there's 20 to 30% of patients diagnosed with major depressive disorder, which are actually resistant to any of these first-line therapies. Currently, right now, from the APA, one of the secondary approaches that can be utilized is something called transcranial magnetic stimulation. And I've set forth here in my change proposal that I believe that this should be utilized as a primary treatment plan. Again, I recommend that utilization of TMS be considered as a first-line therapy for MDD, along with pharmacotherapy and psychotherapy. TMS, or transcranial magnetic stimulation, is a non-invasive procedure in which a magnetic coil is applied to the scalp, and this stimulates nerve cells within the brain and has been shown in many studies to improve the symptoms of depression. Currently, the FDA has approved a treatment protocol, and the treatment protocol set forth by the FDA is consistent of 5 daily treatments per week for 4 to 6 weeks with high intensity TMS, which is the 10 hertz of stimulation, applied to the left dorsolateral prefrontal cortex. So that is one of the common TMS protocols that's used. The second commonly used protocol at this time is applying a low frequency TMS stimulation to the right dorsolateral prefrontal cortex. Many studies have shown the safety and efficacy of TMS, one of which is a study performed by Philipsik et al. And this study basically was a pilot that showed not only safety and efficacy, but efficacy of the TMS for treatment-resistant depression. And it looked at protocols with 28 patients that were receiving 20-minute sessions twice a day for 10 to 15 days. The primary outcomes that were looked at in this study were the Hamilton Depression Rating Scale versus the discontinuation due to adverse effects. And the secondary outcomes were response to the Beck Depression Inventory scores, response, remission, and daily changes versus adverse effects. This study showed by primary outcome measures that there was a statistically significant decrease in the HDRS scores after only 10 days of treatment with TMS. Another study by Pridmore et al. Included 39 participants, which were recruited from an inpatient hospital in Australia. Now, in this study, they looked at patients who had already been responsive to TMS therapy, but had had a relapse within 3 months of their second course. And this looked at the Hamilton Depression Rating Scale, the Visual Analog Scale, and the Clinical Global Impression Scale for severity as to the efficacy of treatment after patients had already been successfully treated previously. And this did show pre and post treatment scores for each scale were compared using sample t tests, and it did show that there was a significant reduction in depression based on all of these outcome measures. A study by Roach et al. In 2020 was a retrospective study, and this was a very interesting study because it actually looked at active deployed military who were being treated for treatment-resistant depression. And the outcome measure on this study was the PHQ-9. And this study reported in its results that patients being treated with repetitive TMS showed a huge improvement in their symptoms of depression after being treated with TMS. So cortical excitatory and inhibitory imbalance hypothesis and neuroplasticity hypothesis have been proposed regarding major depressive disorder. So prior, there hadn't really been a good meta-analysis of TMS neurophysiology that had been performed. So in this meta-analysis by Kinjo in 2020, they were setting out to compare TMS electromyogram findings between patients with major depressive disorder versus healthy controls. They looked at whether patients with MDD had lower short interval cortical inhibition, which would reflect GABA receptor mediated activity, lower cortical silent period, which would represent GABA receptor mediated activity, higher intercortical facilitation, which would reflect glutamate and methyl D-aspartate receptor mediated activity, and the lower result of paired associative stimulation paradigm, which would show the level of neuroplasticity in comparison with your healthy controls. And they further looked at the effect of clinical and demographic factors that could also influence TMS neurophysiological studies. So basically what this study, what this meta-analysis showed overall was that when compared with healthy controls, it suggested that repetitive TMS was a very viable treatment to target the underlying pathophysiologic impairments associated with depression. It looked at the PAS analysis, which indicated a lower level of neuroplasticity in patients with major depressive disorder when compared with those healthy controls. So this was a very useful meta-analysis that was performed, and also drawing in those thoughts and hypotheses of the neuroplasticity. So one of the reasons that I've proposed TMS as a therapy for initial treatment even of major depressive disorder is that there are very limited contraindications for use. Basically, personal or family history for seizure disorder would be a contraindication due to a limited study sample very early on in trials that actually elicited a seizure in patients with very high continuous stimulation. After they had made some adjustments for that, there had never been a report again of seizure, but nonetheless, that is considered one of the contraindications. Also, contraindications would include anything that would increase the risk of seizures in patients to be treated, such as patients being that are withdrawing from alcohol, or any patients that had a new brain lesion that could precipitate seizures. Other contraindications for TMS would include any metal clips in the head, and also they've listed pacemaker as a contraindication. However, I've read in many studies that oftentimes when you collaborate with the cardiologist, sometimes they can just turn off the pacemaker for the treatment period, and thus it's not an absolute contraindication. Also, one of the reasons that I propose this for a treatment for major depressive disorder as a first line is that there are very few side effects to this treatment. We see day to day in our patients as far as initiating with SSRIs, they frequently have a lot of side effects. So one of the side effects is a post-treatment headache, which typically can be alleviated with any of your common over-the-counter analgesics. Scalp irritation can occur. The machine is very loud and often requires ear protection. But for some patients that, is a limitation, and some patients have stopped their treatment because of that. Also, there is some limitations in coverage. So many private insurances are covering TMS based on not only its safety, but its efficacy in treatment. However, many plans are still not covering with very good coverage at this time, also including Medicaid and Medicare. So there's limited coverage for this. And of course, this would be a limitation, as many patients would more than likely not be able to pay out of pocket for the treatment. One of the final limitations would be frequency of treatments. It could be very difficult for patients who go to school or have other obligations such as work to be able to attend the frequency of treatments that are needed for a successful outcome. So my change proposal is that due to limited side effects and proven efficacy of treatment with TMS, that it should be offered as a first-line therapy for major depressive disorder. Thank you very much. This is a list of my references that I've used. I hope you've enjoyed my presentation. Thank you.